Thank you, Stathis. Thank you, Daniel, for this introduction. And thank you for giving me the opportunity to join your meeting. To me, it's a real honor, and I just regret I cannot be there with you. Yet I'm very happy I can give this talk at least remotely. So in the next few minutes, I will introduce you to AL amyloidosis, and I will address briefly the pathogenesis, the diagnostic process, and staging. So we need to keep in mind that amyloidosis is not a single disease. It is a group of diseases. I would say a large group of diseases. We now classify 42 different types of amyloidosis in humans. And what makes these diseases similar to each other, what makes them belong to a group, is the fact that they are characterized by amyloid fibrils depositing in the tissues. But while the amyloid fibrils are probably a final common pathway for protein deposition in diseases and in tissues, the proteins that can actually originate the amyloid fibrils are very different. And each disease is caused by a different protein, and so we have also different treatments for the diseases that we are now able to treat. We have 42 types of amyloidosis, but the types that we encounter in our clinical practice most commonly are less, and are summarized here in this table. So we have light chain amyloidosis that, as you very well know, is caused by a small clone producing immunoglobulin light chain that can deposit in tissues. We have amyloidosis caused by transthyretin. This can be hereditary when you have mutations that increase the amyloid propensity of transthyretin, but this can also be, excuse me, caused by the wild type protein in the ATTR wild type amyloidosis, because this protein has an intrinsic propensity to form amyloid in tissues. So with time, and probably with other unknown factors in addition to time, this protein can give rise to systemic amyloidosis. Then we have rarer hereditary forms, and in this table you can see a polypoprotein A1 hereditary amyloidosis that is relatively common in Italy, and we can have amyloidosis reactive to chronic inflammation, AA amyloidosis. I am also listing amyloidosis caused by leukocyte chemotactic factor 2. This is very rare in continental Europe, but you can see this particularly in people originating from the Caribbean or Latin America. So as you can see in the table on organ involvement, there is a significant overlap of the clinical manifestations of these diseases. In AL amyloidosis, the background of the disease is a B cell clone that is most commonly a plasma cell clone, but you can also have other types of B cell clones that produce a monoclonal light chain that is unstable and can misfold and aggregate, forming amyloid fibrils that deposit in tissues. And of course, it is not good to have amyloid deposits in vital organs, but particularly in AL amyloidosis, the circulating precursor or the circulating oligomers formed by the precursor at early stages can exert a direct toxicity on tissues, particularly on the heart. So this toxic part of the pathogenesis of the disease is an explanation of how the light chain amyloidosis can progress fast, but also is the reason why, as you will hear from Professor Kastritis, when you can reduce the concentration of the circulating precursor, then you can have a relatively rapid improvement of organ dysfunction. The clinical presentation of AL amyloidosis depends on the organs that are involved. And most commonly, we have involvement of the heart and of the kidney, as you can see. Heart involvement manifests with heart failure, arrhythmias. This can contribute to hypotension that can be very severe. It is usually associated with involvement of the autonomic nervous system. Renal involvement manifests with proteinuria that can progress to nephrotic syndrome and renal failure. You can have involvement of the peripheral and autonomic nervous system. This is rarer but important in the disease, and is something that you have to keep in mind when treating the disease, because these patients are prone to symptomatic hypotension, even if they don't manifest symptoms of hypotension at baseline. Then you can have involvement of soft tissues. This soft tissues involvement gives rise sometimes to pathognomonic manifestations of the disease, such as macroglossia or the periorbital purpura that you can see in the slide. Sometimes, however, despite these soft tissues manifestations, very strongly point to AL-type amyloidosis, these manifestations are late, and unfortunately they are rare. So it is difficult that you have this help in recognizing the disease. I would like to draw your attention to this survival curve. Professor Kastritis knows that I am presenting these slides quite often at meetings. And the issue is not just that we are improving the outcome of our patients with time. I am more interested in this case to draw your attention on the shape of the survival curve. This is almost that of an acute disease. We have a fast drop at the beginning, and then, particularly now with novel treatments, we are reaching a plateau. So based on that, I think we have to make some considerations. First of all, we don't want to lose patients at the beginning. So we don't want to see patients with advanced disease. So our diagnosis needs to be early, but also accurate, as I will discuss later, because you have to be sure that you are confronted with AL-type amyloidosis. It is clear that the manifestation of this disease is very heterogeneous. So you need a very accurate risk stratification that is a support for the design of the therapeutic strategy. And then you will hear from Professor Kastritis that you need to assess a response continuously during treatment, and you need to be ready to switch early to rescue treatments in the patients who do not respond early. So we want to get in the highest possible proportion of patients to the late plateau phase of the disease. We want to see this plateau phase rising higher and higher. So the first step is to recognize, to diagnose amyloidosis. And I am presenting here a few quite similar cases. These are three men who have a low intermediate risk MGUS with an IgG lambda, rather small, with a small plasma cell infiltrate, and who present at the beginning, at the time when the monoclonal component is detected as asymptomatic. If we look at the first patient on the left, this gentleman, after 2 years, had to reduce his antihypertensive medications, and then hypertension resolved. And then after 1 more year, the patient experienced a worsening exertional dyspnea. This patient autonomously was seeking a cardiological advice, and according to the echo, as you can see there in the slide, amyloidosis with heart involvement was suspected. The second patient is very similar. And what happened after 2 years of monitoring of this MGAS, the patient had a slight increase of NT-proBNP and proteinuria. Again, echocardiogram was performed, and although less evidently than in the first patient, amyloidosis was also suspected. And that patient, the second patient, did not have symptoms. The third patient is a little older. Before the diagnosis of MGAS, he had a hip replacement surgery and bilateral carpal tunnel syndrome. After 2 years, the patient experienced a reduction of the resistance to exertion with mild dyspnea, and an echo again allowed us to suspect amyloidosis. And these 3 patients were referred to our center. And of course, the next step in this patient should be confirming the suspect of amyloidosis with a biopsy. So in the first patient, we had an abdominal fat aspirator, and a diagnosis of AL lambda amyloidosis was established. And as you can see, the cardiac biomarkers were very high. So this patient was already in a very advanced stage at diagnosis. The second patient at the time of diagnosis was still asymptomatic, and the diagnosis was the same, AL lambda amyloidosis, and again on abdominal fat. In the third patient, abdominal fat was negative, and the patient was diagnosed on an endomyocardial biopsy with ATTR amyloidosis. Genetic testing was negative, so the final diagnosis was ATTR wild-type amyloidosis. So 3 different presentations, 3 different journeys to diagnosis, and 2 different diagnoses in patients who started with a monoclonal gammopathy. And the first patient was diagnosed late. So again, the disease needs to be diagnosed early and accurately, as you can see, because there are confounding factors. We know that the light chains are there at least 4 years before AL amyloidosis manifests, sometimes many more years, but in all patients at least 4 years. So hematologists who are following patients with AL amyloidosis do have time to recognize the disease. And of course, it is difficult to screen for patients who have a rare disease. I mean, it is difficult to screen for a rare disease. So we have to enrich the sample to find populations at risk. We are still not very good at that. Most patients with MGAS who then develop AL amyloidosis have a lambda isotype, but also kappa patients can develop AL amyloidosis. Some germline gene that can be used by the clone to synthesize the light chains, both lambda and kappa, are associated with a higher risk of amyloidosis and are associated with involvement of specific organs. For example, the lambda 6 is associated with kidney involvement, and the kappa 1 with soft tissues, and in other studies with liver involvement. And also kappa light chains, when they are glycosylated in specific regions, are prone to develop, to produce light chain amyloidosis. And in our patient population, most patients with a known pre-existing MGAS also have an abnormal free light chain ratio. So there are means to enrich the sample and to look in specific patients for AL amyloidosis. What we did was looking at patients with an MGUS and abnormal free light chain ratio in this small preliminary study. Over the course of 10 years, we monitored 1,300 patients with MGUS, and 22 of them, 1.6%, with an annual estimated incidence of 2.5 per 1,000 person. We found AL amyloidosis in these patients. And as you can see, all these patients were asymptomatic at the time we diagnosed them. But if you look at the table on the right, one of them already had, excuse me, a rather advanced cardiac stage. Nevertheless, all patients had time to respond to treatment. And none of these patients in this small group actually died of amyloidosis. There were deaths from other causes, but not from amyloidosis. So this was just a pilot study. So I'm not able to say that it is convenient or cost efficient to do this type of screening. This was just a study to show you that the screening for AL amyloidosis and MGUS is feasible. Probably you can enrich the samples now with advanced technology for patients at higher risk rather than using only those with an abnormal free light chain ratio. So this is our flow chart to diagnose systemic amyloidosis. We start from signs and symptoms, and then if you don't know that a monoclonal component is present, then you look for this as the first step. If there is no monoclonal component, you start a diagnostic workup for non-AL amyloidosis. This will be discussed tomorrow. And if heart involvement is suspected, then you go for cardiac scintigraphy, and this will be the topic of your session tomorrow. If there is a monoclonal component, you need a tissue biopsy that needs to be characterized adequately. But if you are hematologists and you are following patients with MGUS, there is a possibility to do a biomarker-based pre-symptomatic screening of MGUS, and then you have to do staging. Now it comes to biopsy, which is the preferred biopsy. This differs from center to center, so you should not impose a biopsy type to your pathologist. For hematologists, the combination of abdominal fat aspiration and bone marrow actually reaches a rather high sensitivity, almost 90%. But you should not hesitate to go for organ biopsy. The problem is typing. And with typing, usually immunohistochemistry, light microscope immunohistochemistry with commercial antibodies does not work very well due to low specificity. In the left panel, you see a published patient by Satoskar, quite an old case. The patient, this is an endomyocardial biopsy. The patient had lambda AL amyloidosis, but as you can see, the patient had a strong staining for TTR. There are antibodies out there that are specifically raised for amyloid proteins that increase the specificity of these antibodies for amyloid proteins. This can be found in Germany and Japan. At our center, we use immunohistochemistry on electron microscopy because this reduces the background effect, because you see the gold particle that actually is very close to the amyloid fibrils. So this is just the reason why it is accurate also with commercial antibodies. And most referral centers now or have already shifted to mass spectrometry that has the advantage to be very sensitive and not dependent on antibodies. So you don't have the problems of lack of specificity of certain antibodies, and also being not dependent on antibodies, you have the opportunity to detect new forms, new rarer forms of amyloidosis. So that's important for research purposes. However, you need the instruments and you also need expertise. What I'm coming to understand now is that all the referral centers who use mass spectrometry are not using mass spectrometry alone. For instance, the center in the UK is using immunohistochemistry before mass spectrometry, and in many instances also the Mayo Clinic is doing that. So availability, accessibility of technology is a problem, is a barrier to amyloid typing. This is the results of a survey that was carried out by Professor Naiki, the president of the Japanese Society of Amyloidosis. This was done for the International Society of Amyloidosis, and many referral centers worldwide responded to this survey. And as you can see, the problems is that lack of access to technology, lack of access to expertise, and also a lack of standardization and the need to send samples outside the centers making diagnosis. Personally, I think that the sending samples is unavoidable and is actually good. We just need to build networks. So it's that's the reason I'm very happy and proud to present to you today, because the national network that you are building is the first step. But I believe, and the International Society also strongly believes, that we should go beyond national networks, building international networks, and really making accessible to ideally all patients typing with adequate technology in a reasonable time and at a very reasonable cost. Let us now move to staging, which is the last part of my presentation and the last step of the diagnostic process before moving to treatment. And let us be back to the pathogenesis. I was mentioning that you don't only have the amyloid deposits, but also direct toxicity of the circulating light chains. And this toxicity is exerted on the cardiomyocytes by activation of the p38 MAP kinase pathway that then causes oxidative stress, as you can see in this very nice slide by Professor Sancho Ravala. But the p38 MAP kinase pathway also promotes the synthesis of NT-proBNP. So in AL amyloidosis, NT-proBNP is a stronger, more important marker of heart dysfunctions than in other cardiac diseases. And just dividing our patient populations based on quartiles of the level of NT-proBNP, you can achieve this very nice discrimination of survival. So NT-proBNP is a special marker in AL amyloidosis. And we have staging systems based on cardiac biomarkers. The first one was proposed in 2004 by the Mayo Clinic and then updated by the European network. I'm presenting the updated version. You see that there are patients without heart involvement who have a very long survival, which probably will become even longer with the treatments that we now have. And we have the black curve, patients with very advanced heart involvement, like the first one that I presented to you. And these patients have a very, very poor survival, as you can see. The Mayo Clinic refined their staging system, including the concentration of the light chains. And you can see here that the discrimination is very sharp. The light chain here is not only a marker of the bulk, but it's also a marker of it's also the very toxic agent that causes cardiac dysfunction. So I would say that also this staging system is a cardiac staging system. But NT-proBNP, a high level of NT-proBNP, 8500, that defines the very advanced stage with the Mayo 24 staging system, is also able to divide into two groups the Mayo 2012 stage 4. And studies are underway. This is a very elegant study from Professor Vechalekar at the NEC in London that was presented at the ASH last year, showing that GLS can also discriminate stage 3B patients. And probably stage 3B patients with a good GLS. GLS is global longitudinal strain, a marker of systolic dysfunction, regional systolic dysfunction at echocardiogram. These patients are hidden into the large group of stage 3B. And if GLS is not so bad, they can have a better survival, and validation is underway of this new observation by the NEC. You can also stage renal involvement with proteinuria and GFR. Again, I would like to emphasize that reversible stages exist. Stages with low proteinuria, with high glomerular filtration rate, can be reversible. So if you diagnose these patients at an early stage with renal involvement and you treat them, you have a very good chance that they don't progress to dialysis. And what about the clone? Is the clone really not important when staging AL amyloidosis? Well, we can have a myeloma-like phenotype. This was a study by the group in Pamplona by Bruno Paiva, who demonstrated that very few patients with a multiple myeloma-like phenotype exist, and have, as you can see here, a very dramatic, a very bad survival. And also chromosomal abnormalities are important. Translocation 1114 is the most common chromosomal abnormality seen in approximately 50% of patients. This is associated with low response and shorter overall survival with bortezomib, but there is no effect with melphalan and daratumumab. So now that we have data, as you will hear from Professor Kastritis, the importance of this translocation frontline is lower, but this translocation is also indicating that the cells are dependent on BCL2. So the presence of this translocation, as you will hear, is telling you that the patients may respond to BCL2 inhibitors. So this is why we know we need to have this information from the beginning. Gain 1Q21 is seen in approximately 25% of patients. It's associated with higher plasma cell infiltrate and with lower response to lenalidomide and possibly daratumumab. We have conflicting data on that. Trisomies are seen in 20% of patients, and there are some reports that they are associated with poorer overall survival. So I hope I could really set the stage for the presentation by Professor Kastritis. I hope I made it clear that the diagnosis of AL amyloidosis needs to be early, and we can really save lives by doing this, and accurate. We can really apply the right treatment if we can do that. Networks are really important. Advanced heart involvement is still an unmet need, but we will be able to stratify better these patients, and I'm sure with improving treatment, we will find a way also for these patients. I am really grateful to you for your patience with me and for inviting me at this meeting. I just regret I couldn't be with you. Thank you very much.
Thank you, Giovanni, for this excellent presentation. In the room, we have a lot of hematologists. We have a lot of patients with MGUS. What is your advice? We need active screening for these patients. What we have to wait some clinical symptoms to do it?
Well, this is just a personal opinion, of course. What we are doing at our center with the help of our hematologists is to test all the patients with MGUS and an abnormal free light chain ratio with biomarkers of heart, BNP, kidney, proteinuria, and liver alkaline phosphatase involvement. This is very rewarding because sometimes we see patients when they don't know that they have amyloidosis, and we can really treat them early with any treatment we like at a very early stage. And it is good to see that these patients do not even realize they have the disease. But, you know, that's just our way to do it. And I can't say that it is cost effective. And I just would like that other centers join, and I would like to do a larger studies, but this is extremely difficult because we need really large numbers of patients. We have a national study in Italy now that is being extended to other hematology departments outside Pavia, but I think we will need many years to reach the numbers that are needed, and it is possible that we will run out of funding.
Other question, Professor Castritis, please.
Giovanni, thank you for the excellent presentation. Again, you set the stage for many questions. Now, regarding the screening, because I think this is very important. One of the problems that we face, I mean, we try to follow your policy. And one of the problems that we face is how to really exclude the presence of AL amyloidosis in a patient with abnormal free light chains and abnormal NT-proBNP and slightly abnormal troponin. Okay, so in this patient, we start by, since we suspect amyloidosis, with cardiac echo, which is sometimes suggestive, sometimes, most of the times not. And we do fat pad aspirates. So the question is, how can we be sure that we really exclude amyloidosis? And I would like to have your approach to this in a patient in which everything is negative. I mean, the biopsies are negative.
Thank you, Stathis. That's really the point. And actually, that was the dilemma that we first had with our first patient, because we had a patient like the one that I presented who was very healthy with a NT-proBNP that was around 600. And then the echo was normal. We did an MRI. The MRI had LGE, late gadolinium enhancement. So they said that this was amyloid, but we didn't feel, we were not sure. So we went monitoring these patients until the NT-proBNP increased, the abdominal fat was negative. So we treated this patient when the NT-proBNP had reached 1100. And so we saw progression, we saw a reduction of GLS. And still, you know, we detect low levels of NT-proBNP, and sometimes also MRI is normal. So that's really a nightmare. What we do now is to monitor these patients closely and to start treatment when we reach cardiac measurable disease in the absence of other causes that may explain the increase in NT-proBNP. So let's say that we find 400, we just follow the patient. When it goes above 650, we do echo and MRI, and we increase monitoring. So it's very expensive. And I do agree with you that that's the real main problem.
Can I also make another question?
Yes, please.
what about the amyloid assay? So, of course, you know more than anyone else about the amyloid assay, and it seems that it could be, if confirmed, a good approach to early diagnosis, at least in my view. What is your view on that one? And second, what about the new tracers? Because we are approached by several people who claim that they have new tracers that can identify cardiac amyloidosis early.
Thank you, Stathis. Two very, very important questions. Thank you very much. So first, the amyloid. I agree with you. I hope that we can see high levels of amyloid, of this amyloidogenic light chains in patients we screen. We have stored the sera, and we asked the company to be able to measure to use the amyloid test in the stored sera of these 25 patients that we found with pre-symptomatic amyloidosis. We also have, we don't have sera for all the 1,300 of other patients, but we also have the control. So I really hope that we will be able to answer these questions, and I'm seeing the people probably in June to start the study, and of course we will keep you updated. Second problem is the tracers. That was also our hope. So we had a prospective study that we presented at the ISA 24 meeting last year in Rochester. And this included very early diagnosis, but my feeling is at least the florbetaben is not sensitive enough to detect early stages. So we need a study also for early stage amyloidosis, but this will be even more difficult with amyloid, because of course we don't have all the tracers, and patients progress. So I have only an experience with florbetaben, which is a good marker, but it's not sensitive enough.
Thank you.
Thank you. Any other questions? There.
Hello. I have a question. I have a patient that has hereditary TTR amyloidosis and also has MGUS. So she has quite an impressive involvement of the heart. My question is how would you differentiate the heart involvement, if it's AL or maybe it's TTR? So the patient has a mutation present, so she has a TTR mutation.
I mean, she had a pathogenic mutation,
yes.
And also we have to say she had 86
years
86.
old, yes.
Yeah, and I couldn't hear very well the beginning of the question. Has the patient also a monoclonal protein?
MGUS.
An MGUS, okay. So what we do, we also have these patients, and what we are doing is to perform an endomyocardial biopsy, and we use immunoelectron microscopy, because there are also cases with double depositions of both light chains and TTR. And so what we are doing is to see whether the fibrils are made of light chains or TTR. Sometimes you have both light chain and not in the same fibrils, but you can see this double staining at immunoelectron. And then we also use mass spec, and sometimes we are able to find the mutation in the TTR, but that's more difficult and not really necessary. And that's a good point, because I think there are a few patients out there with a double amyloidosis, and yeah, so you have to go for a cardiac biopsy, and you have to do typing. I think immunoelectron microscopy is better than mass spec, because mass spec is kind of quantitative, So for double amyloidosis, you need to really have a very experienced center. Immunoelectron is much easier to interpret because you see a double staining.
Thank you. Also, I have another question, if I might. I have also a patient that is around 65 years old, male, and he has MGUS diagnosed, and also he has carpal tunnel syndrome and a positive congruent fat pad, but nothing else, no other organ involvements. So I was wondering what would be your management recommendation?
And could you type the deposits?
No.
Okay, so if it's only carpal tunnel, you are not really in a hurry if this is AL, but you should be sure that that's AL. I'm not sure I could hear the other clinical manifestations. It's carpal tunnel plus?
Nothing else. He only has carpal tunnel.
Yeah, so that's very difficult because orthopedics sometimes are not able to find the tissue. I would not start with, if you don't have typing, I would not start. I would try to do typing. And only if you are really sure that you are treating the right amyloidosis, you can start from the beginning.
Thank you.
Please, any other questions? Sorina Badelița from Clinical Institute.
Morning, Professor. Thank you. I would like to ask you, we have a problem with staging of IL for the patients who had not just nephrotic syndrome, but they have chronic renal failure and NT-proBNP higher, and not cardiac involvement. The cardiologist told us the echocardiography or MRI are normal, but we have a huge NT-proBNP. How we can staging these patients?
Yes, that's always been the problem with BNP. At the beginning of the story, we preferred using BNP and not NT-proBNP in these patients because we also had a paper, I think 10 years ago or more, showing that staging with BNP rather than NT-proBNP was more accurate, predicted better survival in patients with renal failure. Still, NT-proBNP is a prognostic in these patients. So it depends on the level. If you want to discriminate between stage 1 to stage 2, as I think is your case, because you're not sure that the patient has amyloidosis, this can really be difficult. So practically, I stay on the safe side and I monitor these patients also for heart involvement, but that's not really a clinical problem. I mean, it's just a classification problem. If you are using biomarkers to find very high-risk patients, I think when you have a NT-proBNP around 9,000 or so, it is difficult to say that these patients are really stage 3B. So sometimes these patients can have a restricted access to medications in our country because of that, because they have a NT-proBNP that's not really so high. So that becomes a practical problem. Also, in the study that was done by a couple of years ago by Marco Bassett, one of my co-workers, he observed that among stage 3B patients, those with renal failure had a better outcome. And probably it was because this was not really stage 3B. So you can rely on this cum grano salis. So practically you should be aware that you can sometimes overestimate NT-proBNP, particularly when defining stage 3B. This, if in your country you have limitations to accessing drugs for stage 3B, can be a problem for a patient.
Yeah, it's a problem with autologous stem cell transplantation. They don't want to transplant this patient.
Can you repeat, please? Because
we have a problem regarding access to autologous for transplantation. They don't want to transplant this patient.
Okay, so for NT-proBNP, the threshold is 5,000 for eligibility to transplant. But I think also renal failure in these patients can be a problem. So we usually do not transplant patients who have a glomerular filtration rate below 50, particularly now that we have effective drugs to treat these patients. So I do understand your point, and you are really right, because the patient can have a NT-proBNP slightly above 5,000, and then the hematologists don't want to transplant these patients. But I am not transplanting patients with low eGFR now, because you can't do full dose melphalan, you know.
Yeah, and another question, one practical. Many times we have a patient with multiple myeloma and IL amyloidosis, and it's so tricky when the patient with multiple myeloma is with translocation 11-14, because it's a low risk. But if he have a sign of amyloidosis with hepatic involvement or renal involvement, translocation 11-14, it's a high risk. Many times we don't know how we treat it, more aggressive or less aggressive.
Well, I think Professor Kastritis is master here, and I would like to hear his opinion also. When we have these patients with amyloidosis, we try to be aggressive. I think that, for instance, to us the problem is whether or not to proceed to stem cell transplant, for instance, when the patient gets to CR. So for us, the coexistence of multiple myeloma, in any case, irrespective of the chromosomal abnormalities, is a reason to do a more aggressive treatment and prolonged maintenance, which we would not do with what was called primary AL without myeloma. But probably I am too simplistic, because we are not a hematology center with just an amyloid center. So all patients who come to my center have the main problem are caused by AL amyloidosis. So I don't know if you would like to comment, Stathis.
Yes, thank you, Giovanni. I think you are absolutely right. We cannot put every patient in a single treatment. And for patients who present with other myeloma features, whether it's slim crab or just 50% plasma cells, I think we must be more aggressive. I mean, these are the patients in which we consider consolidation, intensive consolidation with autologous transplantation, provided that these patients also are eligible for transplantation with the amyloidosis criteria. These are the patients for which, for example, after 6 months of DARA VCD, I would consider that daratumumab alone as a maintenance may be non-optimal. So these are the patients that I would consider, adding something more in their maintenance. We know, for example, that for myeloma, the best outcomes are with lenalidomide, continuous, with added daratumumab, but we don't have enough data to support that daratumumab alone for 18 months is a good treatment for someone with myeloma. So these are the cases that I would discuss very carefully, evaluate the involvement by the amyloidosis and also the characteristics of myeloma. But generally, I would like to be more aggressive because, as you showed, these are the patients that maybe later in their survival care, they are the ones who relapse. And this is what we are trying to avoid. If we save them with the initial drop of the survival curve, then these are the patients who relapse. And in these patients, the cytogenetics are important, the tumor burden is important, the circulating plasma cells are important, and the depth of response probably is more important, including the evaluation of MRD.
Thank you.
Any other questions? The last one is from me, Giovanni. Is regarding therapy, is regarding diagnosis. Of course, it would be very nice to have the access about mass spectrometry, but unfortunately we do not have this one. Also, you spoke about immunoelectron microscopy, about immunohistochemistry. So you show us even the routine immunohistochemistry, what we done for other hematological disease like lymphoma. Here in light chain amyloidosis can be a problem due to the avidity from the antigen. So in the real life, we based on the Congo red. And I would like to ask you, you have a huge experience in the field. How much confidence you have to have in this staining? What mean negative results? And what are the limits from Congo red staining?
Yeah. Thank you, Daniel, for this question. As you know, I am also struggling from the organizational standpoint for the Italian network, and so I'm very well aware that there are problems of accessibility of typing. But let's talk of Congo red. So when we set up Congo red at our center, I was a young student, and I had the fortune to work with Per Westermark remotely. At that time was difficult to set up the staining procedure at our center. So it's a matter of experience. You have to do a lot of stainings because you have to get accustomed. At the beginning, we had false positives with Congo red. With Professor Westermark taught me that should be impossible. You should not have false positives. Still, many samples and a few patients are coming to our center with positive Congo red staining that then we cannot confirm. So I think you have to centralize even Congo red in a few centers so that they can gain adequate expertise. And there are a few tricks to increase specificity. But if you do a good staining, you don't have issues of specificity. Then false negatives are possible. So and there is nothing to do. This is because sometimes in the sample you simply don't have amyloid, sometimes because the organ has a focal distribution of amyloid deposits. So if you believe that the patient has amyloidosis, but your first biopsy is negative, Congo red is negative, you should not be afraid to do a second biopsy. Sometimes we do that, very often I would say, because we start with bone marrow and abdominal fat if the patient has a monoclonal component, only abdominal fat the patient hasn't. So to us it's really very common to do organ biopsy, particular cardiac biopsies, because we are in a hurry with the heart when the heart is involved. So we are really doing many cardiac biopsy at our center. I think I am by far the greatest provider of heart biopsies to my cardiologists, despite the hospital in Pavia is very large. Coming back to typing, if I may, I am now having a growing interest in light microscopy immunohistochemistry to increase access to adequate typing. I have been discussing a lot with Professor Naiki, both in the framework of the ISA and in our collaboration, and I think this is the availability of good antibodies to type amyloid is probably the way to grant access to a large group of centers diagnosing amyloidosis, and the aim would be to have good antibodies for kappa, lambda, and TTR, which would exclude the most common types. And then you could upscale sending to a referral center. So for us, even if we have now 4 centers in our country, Italy has 60 million people, and we have 4 centers. It's a very good situation for us because if you think of it, I think that the concentration of typing centers in our country is even higher compared to the population that in the United States. So it's really good. But we are faced with an incredible number of patients. Now, last year, we did more than 1,500 typings for the country only in Pavia. So this is something that we cannot really face, and we need something more. So my idea for our country is to set up a few centers doing light microscopy immunohistochemistry as a first pass, and then upscale only when it's not reasonably lambda, kappa, or TTR. But again, we need to think in a continental scale. Of course, I am dealing with Italy, but that's not enough. This will not work. This should be done at a continental scale to provide different technologies.
Thank you very much. Thank you very much for this excellent presentation. We appreciate your efforts to be with us. Thank you very much again.